All right, so let's talk carpal tunnel. Frequently, we get these referrals where a patient is having numbness and tingling, specifically in these first 3 fingers, the thumb, the index, the long, and a little bit, about half of the ring finger. The reason why is because we have 3 nerves that come to the hand. There's what's called the median nerve that does these 3 fingers, the ulnar nerve that does these 2 fingers, and then the radial nerve, which really does kind of the back of the hand. And those nerves provide function for motor and moving all of our fingers, but also for most people with carpal tunnel, that's the biggest concern, is the sensation. They can't feel things. Frequently with carpal tunnel surgery, you'll end up saying, hey, I can't hold on to my coffee cup, I'm dropping it, or I drop my keys, or very difficult to do a button in my shirt because I can't feel it. And so what we do for carpal tunnel surgery, or what it is rather, is if you look right here, you can see these are the carpal bones right here. Arching bones right here will create this kind of upside down arch if you look at it. And this upside down arch is the carpal area, and then there's a ligament that comes up across the top called the transverse carpal ligament. And so if you look carefully, we kind of create this little tunnel with this arch of bones and that ligament on the top. And what's going through there is all of the tendons of our fingers, as well as our nerve. So if this is the carpal tunnel, the row of bones, all of the tendons are going and the nerve goes, and then there's a ligament on top. You can see how the nerve could get actually pinched out. And the tighter that compartment is, because of swelling from overuse of your tendons or things like that, the nerve isn't getting the blood supply that it needs to function. So you're not having the sensation that you need. You're not having the strength that's going to the muscles, because the signal, like a wire in your house, isn't communicating from your brain to your hand what it's sensing or what it's trying to move. So what we do first with carpal tunnel treatment is try to prevent surgery. The first thing we do is, what can we do to put the hand in the best position so it relaxes those tendons and decreases the inflammation? We talk about bracing at night. And if that doesn't work, then we do bracing during the day. And if that doesn't work, another option would be to inject a steroid into the carpal tunnel to help reduce the inflammation. A lot of people are scared of those injections and the fact that there's a needle in their hand, but realistically, patients tolerate those very well. A lot of times it'll help to reduce that swelling. But if that doesn't work, you're starting to have numbness and tingling that's a little bit more permanent, or you're starting to have weakness, we do what's called an EMG, or an electromyography study. And what that is to be able to test the speed of the nerve that's traveling through the carpal tunnel. And a lot of times that'll be reduced. And when that's reduced, we mean that the nerve is being compressed too much. And once you start to see more permanent damage, you're starting to see weakness, at that point we recommend carpal tunnel surgery. What carpal tunnel surgery is, again, all we're doing with this row of bones is that ligament on top, we're just going to go ahead and cut it so it opens up that space for the tendon and for the nerves to be able to function. The nice part about that surgery is it takes very little time. For me, it's about 5 minutes, and our patients are back up. They're moving their hand right away, and there is an incision. There's 2 ways to do this surgery. One is to do it through a scope, so there are very small incisions, and another way to do it is just opening it up completely as it is. The research shows no significant difference realistically between those 2 long term, but in general, the recovery is pretty simple in that we need to just keep the incision clean. Don't want to have it getting infected or have any other issues where the incision may open. So not doing too much with the hand other than immediate range of motion. Most patients by about the 4-week mark are back doing everything they want to do, but immediately after they're using your hand and just avoiding anything dirty. With the goal being, we want to get you to get your strength back, your sensation back. And that's also the difficult part about carpal tunnel surgeries. We're not doing anything to the nerve. We're not repairing it, healing anything, or putting any magic pixie dust on the nerve to have it be able to heal itself. We're just decompressing it. And the nerve in general will heal about 1 millimeter per day as it's recovering. And so frequently we'll see patients say, hey, it's better here, or hey, a month later it's better here. And then over time it just kind of gets better closer to the tips. And sometimes we definitely have to inform them based on their EMG. There's a good chance you may not get complete sensation back, but let's prevent it from getting worse, or hopefully try to see if we can get some of it better. But the goal of carpal tunnel surgery being, we want you to get back and being active, functioning, using that hand, and then sensing the life around you so you can be able to function, be back to living your best life.